Hello, thank you for joining this month's Learning Collaborative on the ketogenic diet, separating fat from fact. We will be posting this later on YouTube and you'll be able to review it. And in order to receive the continuing medical education credit or MOC credit, you will need to click on the link below and complete survey questions that we know that you attended. Thank you so much and enjoy the talk.
So, hi, I'm Lori Douglas. I'm an epileptologist at Boston Medical Center.
And I'm Catherine Fanning. I'm a pediatric ketogenic dietitian.
So we work together collaboratively all the time, taking care of kids with seizures using dietary therapy. And today we're going to give you an overview of the types of diet that we use, although the primary focus is going to be on the classic ketogenic diet. There's a lot of similarity. So most of what we tell you applies across dietary therapies. So the ketogenic diet is used obviously for intractable epilepsy, so treatment-resistant epilepsy, but it's really gaining light in many other conditions as time goes on. If you were to Google right now, ketogenic diet and treatment, you'll see many other neurodegenerative disorders, Alzheimer's, Parkinson's, ALS, which is Lou Gehrig's disease. And evidence is starting in those fields, but it's certainly not a standard of care in those fields. Brain tumors, particularly aggressive brain tumors like glioblastoma multiforme, there's some evidence that it slows down the growth of the tumor and would also help treat the comorbid seizures from the tumor. Obesity, type 2 diabetes, again, not necessarily using classic ketogenic diet, but some of the lower carbohydrate diets. And then it can be the primary therapy for two particular metabolic disorders. One is pyruvate dehydrogenase deficiency, and the other one is a disorder where glucose doesn't get into the brain very well, called glucose transporter protein deficiency, or GLUT1. So the benefits, one of the reasons that patients will come to us is that they've tried a lot of medicines. They're feeling very over-medicated because they're on so many medicines to control their seizures. And there's a hope that they'll be able to take less medication when they go on the diet. Second, obviously, and most importantly, would be seizure reduction. So if someone's having active seizures and they're not well controlled, this remains a treatment alternative for them. One of the things I hear, I'm hearing somebody typing, just so whoever is typing might want to actually mute their screen. I apologize. So the other thing that I hear from my families, and Dr. Jonas is also online, and I have a feeling she hears from hers, is what families really like is that it's the first time since their child was diagnosed with epilepsy that suddenly they were in the seat of control. They have daily decisions that they make that they feel impacts their child's wellness, and they like that. The last thing that is more scientific and a little bit theoretical, but we really think that the ketogenic diet might be anti-epileptic. What I mean by that is it's not just suppressing seizures, but it may actually be reducing the brain's ability to generate seizures. Most of what I give, seizure medications, although we call them anti-epileptic drugs, AEDs, that's really a misnomer. Most are really anticonvulsants or anti-seizures. So Catherine, who is to my right, is a much better expert in each of these, and so when we start to talk about them, I'm going to be needing her input. But the ketogenic diet is probably the first diet that people are familiar with, and the one, if during your training you heard about, you probably heard most about ketogenic diet. There's the modified Atkins diet, or the MAD diet. There's an MCT oil diet, which is pretty old, but there are ways to use it that it can be beneficial even now. And then there's the low glycemic index treatment. So what is the ketogenic diet? Everyone hears it's a high-fat diet and wishes it was this, because that's what all Americans would like, but it's not exactly that, as you all know. And everyone also has the vision that when they consume the ketogenic diet, they're going to turn into one big fat blob. In fact, when I first started in this field in the 90s, it wasn't so uncommon when we would draw the blood of young children. It would come out milkish. It would be red surrounding white blobs. And that is not the case anymore. We really know how to use a broad array of fats and to make them healthier fats. And none of our kids look like this person in the picture, I will say. So what is it? Well, it's a rigid diet of high fat and just enough protein for growth. hardly any carbohydrate that we use to suppress seizures. When you hear about the classic, you'll hear about something called 4-to-1. What 4 means is there's 4 grams of fat for every gram of protein plus carbohydrate. And Catherine, it's really like 4 grams of fat to protein just about, because there's hardly any carbs.
So minimal carbohydrate.
Especially for growing children, where protein is so important that we really don't get to give them very much. So when you think about where did it come from, how did someone decide you're going to eat this high-fat diet? It really started with the biblical times. So what did you do if a person had uncontrolled seizures? Is you sent them out to the fields and they fasted. But unfortunately, you can't fast forever. In the 1920s, people started to realize, well, maybe there's some science behind all of that. And actually, for short periods of time, fasting would be recommended. And not long after, 1920s, 1930s, several very good institutions across the country started to investigate how do we stimulate fasting. And they found that eating high fat can do the same thing. And that was at Hopkins, Mayo, and Harvard. And I'm sure there are other institutions that would add themselves to the list.
So ketogenesis, or the production of ketones, will start with fatty acids. And those are either derived from the diet itself or coming from adipose tissue. So once those fatty acids are in the blood, they can be converted into acetyl-CoA, and then there's a large buildup of acetyl-CoA that can be translated into these 3 ketone bodies, beta-hydroxybutyrate, acetone, and acetoacetate.
And then they get pumped back out into the blood.
Pumped back out into the bloodstream. Thankfully, they are water soluble and can cross the blood-brain barrier, which is especially important in this diet. So they enter the brain and then are reconverted back into acetyl-CoA that can serve as an energy source and enter the Krebs cycle for energy.
So how does it work? Well, we really don't know. I put a couple of ideas on the screen here, but people might add additional ones. So one is it has anti-inflammatory properties. We know with seizures that when they're generated, a large cascade is triggered within the brain. So cytokines and interleukins, and we think that actually exacerbates seizures. So it has some anti-inflammatory properties. It has some direct anticonvulsant effects. The question is how and why. One theory is that it alters glutamate GABA balance. So glutamate is excitatory in the brain for the most part, and GABA is inhibitory. And it's thought that it decreases glutamate neurotransmission and increases GABA production. There was a review of many studies done in children in 2016, a Cochrane review. And it was really to look at a variety of things. One was side effects, but I thought it would be really important to talk about efficacy here. When they compiled all those studies, there were 427 children, of course, with many different reasons for why they came to keto diet. And the seizure freedom rate really varies, as you can imagine, by population, but it can be as high as 55% on the classic 4-to-1 diet. Just to give you an idea, you may remember from one of the talks that Dr. Jonas gave you, she said if you failed 2 or more seizure drugs, the chance that that 3rd drug is going to push you into remission is around 6 to 7% at best. So this is much, much better than that. And I would say that range, though, for keto diet really varies on who you are. If you look at the MAD diet, the modified Atkins, about 10% get seizure freedom. And then if you look at seizure reduction, you're not cured, they're not all gone, but 85% of people will experience a seizure reduction with the classic keto diet, which again is better than our regular standard medicines. Standard medicines, we look for a 45 to 50% likelihood of cutting seizures in half. So this is better than that. And 60%, which is pretty good, on the MAD diet will experience some seizure reduction. And if you want to talk about this is Catherine's expertise.
So what does the diet look like? And we'll show you a picture as to exactly how the diet itself is broken down. But when you think about the typical American diet, it's primarily made up of those carbohydrates that we're so used to. So about 45 to 65% of our diet is primarily carbohydrate, with 30% coming from protein and only about 25 to 35% coming from fat. And when we're thinking about the ketogenic diet, especially the 4-to-1 classical diet, up to 90% of that diet is based in fat. So you can imagine what that might look like, and how we have to tailor people's different tastes. So it can be a challenge to make this a palatable thing.
I have to say, Catherine's expert at making this palatable for kids.
So this is just an example of what a 4-to-1 meal might look like. So primarily we use fats such as butter, olive oil, mayonnaise, and that will make up the bulk of the 4-to-1 diet. And then we're able to have low carbohydrate vegetables, so things like lettuce, tomatoes, any of the non-starchy vegetables, and then some protein just to make sure that we have adequate growth and development.
Actually, I think this looks good. I would be okay. It's lunchtime, so I would actually be fine eating a kebab with some kind of salad on the side. Looks good to me.
So the modified Atkins diet is going to be a less restrictive therapy, while still really controlling the amount of carbohydrate that we're taking in. Depending on the age of the patient, it might be anywhere from 15 to 30 grams. And it approximates about a 1-to-1 ratio of fats to carbohydrate and protein. The lower carbohydrate limit still helps to push our bodies into a state of ketosis.
Oh, I just want to go back. I guess one of the reasons that we like the MAD diet for our teens and adults is there's less measuring and weighing, would you say?
Yep. So we're able to use standard household measurements as opposed to a gram scale, which is required of the classical diet. The medium chain triglyceride oil diet is certainly more flexible, as medium chain triglycerides have been shown to be more ketogenic, and therefore we're able to use a less percentage of fat, and that allows for more carbohydrate and protein to be taken in. Some source of MCT oil is provided at each meal and snack, so that might be in the form of a salad dressing. It might just be mixed into whatever vegetable or protein that they're having, but there are some GI side effects that can come along with it, though we do use MCT oil pretty much in every single diet to help relieve constipation.
Yeah, and sometimes we use it to boost ketosis, so we may be using a more classic form of the diet, and we'll add some MCT to give just a little higher ketogenic effect, so we may include this with some other and blend it.
These are just examples of the different products that are available. The Now brand MCT oil is one that is on the market for any of our patients to purchase, and some of the other ones might have to be prescribed, like the Liquigen, which is an emulsified formula. And then there's also the use of coconut oil, which has a lesser degree of MCTs within, but is commercially available.
Something we go to, at least for our people that are consuming it by mouth quite a lot. It can be used actually quite creatively, I think. The challenge with the tube feeders, really, you can't give coconut oil because it will clog it. So the low glycemic index treatment, this is a really strong focus on making sure that we're sticking to low glycemic index foods. And what that means is that the foods will have a lesser effect on your blood sugar overall. So we're consuming anything that has a glycemic index of less than 50. And these are typically complex carbohydrates that have a slow degree and rate of absorption. And so in that way, they allow your blood sugar to remain more stable as opposed to inducing a spike. I think we have some examples of how foods differ by glycemic index here.
And so again, this is just the glycemic index is going to relate to how these specific foods will raise your blood sugar over a certain time period. So the ones with the low glycemic index means that we're able to keep our blood sugar more stable.
I usually give my patients this basic rule, like most white foods, white rice, white potatoes, white bread, kind of a no-no on the LGIT. And if you think about oats and whole wheat and quinoa as a complex, the other thing I always say is whole foods versus processed and cooked. So a whole apple versus, say, applesauce would be lower glycemic. So what do you do prior to starting the diet? What typically happens is Catherine and I, or Catherine and Dr. Jonas, one of our doctors here, will get a referral. Sometimes we're the second epilepsy center involved. They're just looking for a ketogenic center. And what we'll do is sit down with the family and gather some information about the child, some information about the family, what are their expectations, and really what maybe boundaries they might have. Do they have the support? A lot of this you have to create on your own. Some of it isn't available off the shelf. So there's time, there's an expense. So we try to find out what's going on from a financial standpoint. And to say our team here has become very expertise in overcoming some of those barriers. We've really been able to make this available for just about anybody, but it really takes a lot of knowledge and a lot of preparation, the more barriers that they might have. We discuss medications with our pharmacists. Most medications that come in liquid form have some amount of carbohydrate, alcohol, or sugar just in the frank form. And we really have to think about, can we convert this to tablet? The one medicine that's very hard to give is valproic acid. And what we actually have to do is give the IV formulation through either oral or through a tube. We want to get a sense of how is the child growing. So if a child has failure to thrive, this might not be our first step. Our first step might be to get the child well nourished. Some of our children who are coming, maybe we're on the side of needing a G-tube. We'd probably encourage that first before we would actually go over to the ketogenic diet. And then we really want to make sure that they're safe to do this. So we'll do a whole number of labs. And they're really broken down into two big categories. One are nutritional labs, like electrolytes, your protein, your minerals, your vitamins, as you can imagine. And then we want to make sure that it's also safe, that they don't have an underlying metabolic disorder. So we'll look specifically for disorders of fatty acid oxidation, mitochondrial disorders, and those are the labs that we're doing here. Organic acids and amino acids, serum, that's actually should be urine acylglycines and serum acylcarnitines. There's a little typo there, I apologize. And then drug levels, some medications may fluctuate with the diet, and then we'd like to make sure that they aren't already starting with kidney stones. The diet can aggravate that, can bring out kidney stones. So is ketogenic diet contraindicated for metabolic disorders? That's true for some of them. We mentioned them already. Fatty acid oxidation disorders, as you can imagine, if you're feeding a lot of fat and your body doesn't metabolize fat, that could be dangerous. Porphyria, unrecognized carnitine deficiency. So if you have a problem with carnitine, carnitine helps shuttle the fat into the cells, that would be a problem. And then some mitochondrial disorders. So what ones are, is it okay? And we mentioned one, glucose transporter deficiency, or GLUT1. And then there is one mitochondrial disorder, pyruvate dehydrogenase deficiency, where this is actually the preferred treatment because you're actually bypassing one of the enzyme blockages. So I'm just going to really include an overview of adverse events, and Catherine and I work closely together to try to figure out how we're going to get past these. First of all, some kids do very, very well, and some are more challenging. One thing that you want to avoid is lethargy. Often that relates to fluids and bicarbonate if it happens acutely. Long-term, obviously, we look at all of the nutrients. Mm-hmm. And metabolic acidosis. So this is something we follow in hospital, and then shortly after discharge if they're coming into a DESA diet, and then we follow it regularly every 3 months. Younger children has been our experience that they have more problems with metabolic acidosis, so the infants more so than the older child, and we treat that with bicarbonate. It can be hard to get sugar-free bicarbonate. Some insurances cover it, some don't. And what we've actually used a lot of the time, though it's kind of challenging to be palatable, is baking soda. I don't know if you want to comment anymore.
I find that both baking soda, for mixing it into either their different foods or for able to incorporate it into some of the drinks that they might have during the day, we can create a level of palatability. But otherwise, like Lori said, it can be difficult to get insurance coverage for things like a potassium citrate, like a citric A, something like that.
Kidney stones, same treatment. In order to avoid them, you want to give fluids and bicarbonate as well. So keeping the alkaline pH is very important in preventing them from accumulating. Many of our patients have been on topiramate or on zonisamide before they come to us, and they may already have kidney stones. So getting them off those meds or reducing those meds can be very helpful as well. Pancreatitis, I fortunately have never seen one, but we do monitor lipids as well as amylase sometimes, and occasionally I think that Catherine's asked me to prescribe some enzymes, creon, pancreatic enzymes, just to help with that. But it's obviously abdominal pain in a child like this, you want to pay attention and get some labs. Constipation, many times the kids are coming in already constipated before we start a diet, and without as many vegetables or fruits as they might normally consume, it can be a challenge. Fluids, there are certain creative ways to give fiber. Dupalax, Miralax are also things that we can give for stool softener, and sometimes just the carnitine that we routinely prescribe helps.
Mm-hmm.
Have you had any other thoughts?
And the MCT oil.
Yeah.
Yep.
Make them more ketogenic and make them go to the bathroom. Yep. We need to follow growth. About in the 1990s, there was a documentary that was put out in a movie, and a lot of people were trying this on their own. We very much discourage that. It really needs to be in a center that does this routinely, where there's monitoring, because we want to be sure that the children are growing properly and that they don't get sick. For bone density, obviously this is true of our seizure medicines just as well. Exercise, calcium, vitamin D, and I think also keeping the acidosis down makes a difference. Optic atrophy, usually you only hear about that when people have been self-treating, and that also relates to a vitamin deficiency, but at the same time I recommend our patients get seen yearly. When you eat fat, you're going to reflux that more. This is something we take into consideration even before we start the diet, I would say. So if there's somebody who's coming to us and is a tube feeder, maybe does not have a fundoplication or has a failing fundoplication, and maybe is an aspiration risk, I worry about those patients because we don't want fat getting down into the lungs. So we have to think about that carefully and what can we do to minimize those problems. Sometimes it's a slower feeding during the day while the patient's head is up. I don't know if Catherine, you have any other suggestions?
There's just ensuring, especially if they're G-tube fed, making sure that the head of the bed is always at least the 30 degrees. Feeding during the day if possible, and avoiding that overnight feed so we don't risk more of the silent aspiration, things like that.
And then we check for a whole host of vitamins and mineral deficiencies, and we monitor the fats. When we start to see a child whose cholesterol is overly high or high triglycerides, what Catherine does is usually modifies the diet to incorporate more PUFAs. Any other thought? More polyunsaturated fatty acids? Very
rarely does it mean that we sometimes have to come down in the ratio of the diet, but ordinarily we're able to increase the polyunsaturated fatty acids. We're able to give things like fish oil, and there has been some preliminary evidence to show that creon can help with the high triglycerides as well as carnitine if their levels are low.
So what do we do for monitoring? And certainly something as the pediatricians that are involved in the children, we're really hoping that you'll co-follow with us for their weight and their height and their head circumference to make sure that they're feeding adequately. We also will do blood and urine. That's usually our primary responsibility. However, should the child be sick, there are some labs that we often will coordinate with the pediatrician to be sure that they're being monitored during times of illness. We talked about the eye exam. We talked about bone density. I'll often do it before we induce, more so for a classic ketogenic diet than an LGIT. So the higher the fat ratio, the more I want to do these tests before starting. The renal ultrasound, again, I don't always do renal ultrasound with a low glycemic. It's more for the ketogenic diet that I would be more concerned. Potentially the MAD diet, just because it is more ketogenic. And then cardiac, I usually will follow the children along, but you really want to make sure you're getting blood pressure, you're getting good vital signs, and if there's any signs of cardiac failure, obviously want to have the cardiology team and potentially an echo involved for cardiomyopathy. Sick day management is something that comes up. So children get sick, and many of the children on the diet are young, so they're exposed to illnesses. And when they're sick, whether it's ketogenic or not, we all know that they're prone to more seizures. But also when they're on ketogenic diet, the other unique thing is their ketone levels may fall. So they release cortisol and there's a stress response. And so that may actually affect their ketone levels. And so sometimes we have a couple of kids I can think of where we actually give them more fat when they're sick. As long as they're not vomiting, we'll actually give them some MCT oil when they're sick. If they're febrile, it's important, again, avoid liquid medications. You certainly can use the suppositories like acetaminophen, again, just making sure we're not overdosing the children. You can use some tablets, but you have to be careful that they're not sugar-coated and that they're crushable. You want to encourage calorie-free, caffeine-free fluids, so some of your diet sport solutions are a good way to go.
It's like a Propel.
Right. Will tend to do, and just giving them, even if they're syringing it in, just like you would with any child who's ill, especially vomiting. We want to make sure that they stay hydrated. Once they get really dehydrated, they're going to become very acidotic, very lethargic, and that can happen very quickly. So we monitor for excess ketosis. Children go home with little ketone strips, so parents can be monitoring this from home. And if we're really concerned, we'll often send them to you or to their local lab to get a set of laboratories checked. And then once they start to recover, we'll slowly increase the fat ratio, increase their calories as they're getting better. A couple of drug interactions just to mention. One is if they should get sick, so propofol is often used in our kids who have intractable epilepsy. It may be used in status epilepticus. It may also be used for getting an MRI or doing a procedure. And it's really important to remember that propofol itself is a fatty acid. So when you're giving it to a high-fat diet, you have a higher risk of producing metabolic acidosis, lipidemia, rhabdomyolysis, and even cardiac failure. So propofol and ketogenic diet don't mix so well. If you're going to use them together, you need to monitor really, really carefully. The other one we've mentioned a few times is carbonic anhydrase inhibitors, so topiramate, zonisamide, and diamox or acetazolamide are all carbonic anhydrase inhibitors, which can lead to more acidosis and kidney stones. Valproic acid can interfere with ketone production and carnitine deficiency. I just say in general, we do pretty well with valproic acid in the ketogenic diet, but our kids may get a little bit more carnitine. Phenobarbital, the levels may increase when they go on the ketogenic diet, so you want to make sure that the lethargy isn't from the medication. You might need to come down on the dosage. And then, as we've said over and over, carbohydrate-containing medications. So antibiotics are really important to consider. So I think most people are used to prescribing the pink bubble gum augmentin or amoxicillin. Kids love that, but full of sugar. So we have to think about using a tablet form is what we usually recommend. Any questions, we are always available. I would say all of our docs are pretty well versed in what medications can be used. We also have access to the pharmacy here who's very good about checking. And our wonderful epileptic nutrition site, which actually is great, is just being rolled over to our Boston Medical Center webpage. And so we're under construction. We'd like you to stay tuned. Catherine has been really instrumental, and dietitians who have worked for the center before have been very instrumental in really creating a family-friendly, patient-friendly site with recipes and demonstrations on how to do this and how to stock your pantry. In the meantime, for all information, give us a call.
Yep.
We'll hope to get it up, I'm hoping by the end of summer. And then we have I had some additional resources, but I think they went away. But maybe you could just talk about some of the other places that people might want to go for information about the ketogenic diet.
So the Charlie Foundation is a wonderful resource. It will detail for you the different variations of the diet, different iterations of them, as well as some of the others as Matthew's Friends.
And then there are several different kinds of ketogenic formulas. And there is one, we're not promoting any one in particular, but Keto V tends to have a lot of information. And so we just recommend that you can look at it and just remember that they aren't the only one, but they certainly have some good information for you. I know that some of our epilepsy team is on with us. I'm just wondering if anyone has any questions. Guess not. Okay.
I
Well,
think
thank you.
it was very clear and a very nice talk. Thank you.
Thank you. Thanks, Dr. Jonas. Any comments from you, Dr. Jonas? Because you have been working with the diet just as long as all of us.
I have to say that I think parents really like it. Parents have a lot against medication, and I think a dietary option, even if it's just an add-on, is something that they like. And we figured out that even families with low income and they don't have a lot of resources can manage. I think this is very important. It's not just for the rich and the ones that have resources. I have to say that Catherine has a lot of imagination and a lot of solutions. And I'm quite impressed with how some of the families that we didn't think that would be able to stay on the diet actually did very, very well with Catherine's guidance.
I agree. Well, thank you everybody for joining. Christina, any comments from you before we close?
I just wanted to leave a final reminder that this talk will be available on our YouTube channel after the fact, and just look on below for a link to complete a survey so that we know that you attended after the fact, and we can apply that towards certifying for the MOC credit or continuing medical education credit. Thank you so much, everyone.
Have a great afternoon.